I'm Charles Nelson from the University of Pennsylvania, and I'll be moderating with James Brown from the University of Virginia. Our first speaker is Jay Parvizi in this important section on infection. So Jay's going to come up and talk about diagnosing the infected total arthroplasty in 2021. Who needs advanced molecular testing?
Thank you, Charles, and again, thank you to Ccjr for giving the podium. I do have a relevant conflict of interest. My institution receives research support from Microgen DX, and I'm also recipient of consulting and IP from Microgen DX, and I will mention their technology. So the task that I've been given by Ccjr is to try to address some of these questions. So who needs advanced molecular testing? And the answer is probably everyone. Why everyone? Is because, unfortunately, culture is negative at about 30, 40, sometimes up to 50% of the time. And by the time you get the culture results, it's a little too late. At that point, you can't send a sample for molecular testing. And in addition, I think a lot of these, well, some of these aseptic loosening cases are probably undiagnosed infection. They were either not investigated properly, or they escape the diagnosis because some of these tests that we have are primitive. The International Consensus Meeting looked into this question, and if you look, they said that the role of molecular techniques such as next-generation sequencing should be explored in this set of patients. And I think there are some patients, some infections that don't elicit enough of a physiological response, and hence they may escape diagnosis. So why have culture-negative PJI? Well, first of all, organisms are not always planktonic. They exist in the form of communities inside the cell, up there in the blue. They could exist in the Haversian canal, as the work of Eddie Schwartz has shown us. They exist in the form of biofilm, which we're all very familiar with. This is a structure that's a sessile. The organisms are covered in the extracellular matrix, the glycocalyx, impenetrable to antibiotics or to the immune system. And they actually communicate through sophisticated molecular techniques like the quorum sensing. Second, this is a new concept, VBNC, viable but not culturable. This is a work of Dr. Lewis from Northwestern that has shown that there are variants of organisms that are tolerant to antibiotics and responsible for recalcitrance towards treatment with common antimicrobials. 0.3% of all the communities are recalcitrant persisters or VBNCs. So if you have 1 billion microbes, about 3 million of those microbes are what we call persisters. So it doesn't matter how much antibiotic you administer, some of these cells will survive and they will come back later to cause the infection. This beautiful paper in Nature shows how the mechanism of recalcitrance and VBNC works. Time doesn't allow me to go into the details, but basically they shut down their metabolic phase, stay dormant. When the appropriate physiological environment arises, they can then get activated and become pathogens again. Culture is primitive. This is what we were doing in the 1880s when culture was introduced. That's the mode of transport. This is how we looked at the skies, and this is how we isolated the infective organisms. This is our mode of transport today. This is how we explore the outer galaxy, and this is how we isolate the organisms. So, in fact, 2% of organisms are culturable. Of all the pathogens known to mankind, only 2% of them can be grown on Petri dish. Again, only 2% of organisms known to mankind can be grown on Petri dish. So what is available? That's the next question I was asked to answer. A few technologies are out there, but what we need to ask is which of these work and which of them have any evidence behind them. We wrote a current concept review, and I think we went through all the technologies that are available, including non-molecular techniques for isolation of organisms in culture-negative cases, including increased incubation time, using blood culture bottles, etc. And time doesn't allow me to go into the details, but of the molecular techniques, PCR has fallen out of favor because PCR can only isolate microbes, 8 to 20 of them at most. You have to know what organism you're looking for in order to be able to utilize PCR. And sequencing, either next-generation sequencing or metagenomics, has found its way into the field, and I think that will become the standard in the future. The cost of sequencing has declined rapidly, as you can see from this NIH grant, which has made this a clinical entity. And organizations like NASA use next-generation sequencing to explore the outer galaxy. These are the microbiomes of International Space Center that was brought back, and they have looked to see what organisms exist out there. And many of these organisms, none of us in this room can spell or pronounce their names. There have been huge number of publications in the field in orthopedics, but other fields are way ahead of us. This is a paper in urology that shows when NGS was used to isolate organisms, it had a better outcome, and it was able to isolate organisms in a lot of these so-called negative culture urinary tract infections. In the field of neurology, this is New England Journal of Medicine paper, again showing that NGS was more capable of isolating organisms when culture failed. What are the pitfalls? Quite a few. This is a technology we don't understand very well. Microbiome exists in our body, so even if you send a sample from a primary knee, you could potentially have positive NGS signal. That's what we call microbiome, non-pathogen commensals. The sequencing doesn't provide you with antibiotic sensitivity. That's been the biggest criticism from our ID group. And in order to do this, what I think needs to happen is something like this kit where you will be able to isolate the organisms and at the same time measure the cell count, neutrophil differential, as well as biomarkers to see if that organism that you're detecting is also eliciting a physiological response or not. If they do, then possibly they are pathogens. If they don't, they're most likely part of the commensals. And then you can measure for the resistance genes. And this particular company does about 17 to 20 resistant genes. And if you can have the resistant genes, then I think you could potentially argue that the organism is going to exhibit antimicrobial resistance. So in conclusion, in my opinion, molecular techniques are here to stay. They will become the standard of care in the future. They already are in many other fields than orthopedics. We've made a lot of assumptions about orthopedic infections in the past, and it's great to see that the young men and women in orthopedics are beginning to examine some of those assumptions and discovering new things. And I think the field of infection is already being revolutionized, and we will see huge accomplishments in the future. Thank you very much.
Thank you, Jay. That was excellent, an excellent introduction to a very important topic. Next, we have Brian Springer. He's going to talk about preventing preoperative infection in 2021, what is worthwhile, what is not.
Thank you, Charles. Good afternoon, everybody. I do not have any relevant disclosures pertaining to this topic. So preventing infection in 2021, what to do and what not to do. This is a pretty crowded space. There's a lot of opportunity. There's some good data, there's some soft data. What I'll try and give you is a little bit of a common sense approach. I'll present 7 things that you can do relatively easily within your practice. Some of them still pose some challenges, and then we'll just touch bases on some things that you do not need to do. Glycemic management. We realize that the surgical stress of surgery antagonizes insulin. This is true regardless of whether or not you're a diabetic or not, and this predisposes all patients to hyperglycemia, which then impairs our immune system's ability to thwart infection. We know that this poses a greater risk for infection in our diabetics and our non-diabetic patients, so maintaining and managing patients' glycemic control in the perioperative period is important, again, regardless of whether or not you have diabetes or not. The data would suggest maintaining a blood glucose level less than 200. Some studies would suggest even having that in the 120 range is important. What is the best marker of glucose control? We most commonly use hemoglobin A1C. The data is somewhat controversial. Most of the studies demonstrate higher rates of complications when it's above 7 or 8. We use a cutoff of 8. Keep in mind, though, that it takes 3 months to change the hemoglobin A1C. It's a glycosylated red blood cell, so it has to follow the life cycle of a red blood cell. So if we're going to use this as your marker and someone has an elevated hemoglobin A1C, it's likely that you're going to have to delay them at least 3 months if you want to hit that target goal. But perhaps it's the magnitude in the decrease of the hemoglobin A1C than crossing some arbitrary line. Jay's group has done some really good work looking at glycosylated serum proteins or serum fructosamine. This only takes 2 to 3 weeks to change, so it's a much tighter marker of blood glucose control over a short period of time. How do we use it? If I have a patient that has a hemoglobin A1C above 8, we don't want to delay their surgery 3 months. We'll put them on a strict regime for 4 to 6 weeks, and then we'll check a serum fructosamine. If it's less than 293, oftentimes we will proceed with surgery. Obesity remains a challenging and emotional topic for us and our patients. I think the data is pretty clear that your complication rates go up as your body mass index goes up. Clearly, there are isolated series that touts the benefits. What we have to remember about obesity is it's a continuous variable, again, and sometimes drawing an arbitrary line in the sand can be challenging. The problem that we face is we practice, majority of us, in a fragmented healthcare system, and what we really need for these patients is an integrated coordination of their care, which we lack in many places that we practice. So what should we do? I think a reasonable attempt should be made to reverse the risk factors. If it's not successful, then you have to factor in the overall assessments of the patient's health and decide whether or not to proceed on an individual patient with that basis, on that basis. But I do think it's important that you optimize the medically controllable consequences of obesity, such as diabetes. Malnutrition, how do you screen for it? Generally, serum albumin less than 3.5. The challenge is if they are deficient, what's the best way to replete their nutrition? There's a lot of different options out there. There's not necessarily great data on what is the best and easiest way to do that for our patients. I think we all understand what the systemic and local effects of smoking and nicotine is in our system. I probably don't need to belabor those points. The data is clear that patients that are actively smoking have higher risk of any postoperative complications, deep infection, and death. What we do know from the pulmonary literature is that you need to quit somewhere around 4 to 8 weeks prior to surgery in order to start to normalize your metabolic and immune function prior to surgery. But what we also know is that even if you quit smoking, your complications don't normalize to that of a non-smoker. They probably fall somewhere in between. The challenge is it's really hard for these patients to quit. You can monitor it by checking a serum cotinine level, which is a metabolite of nicotine. It has a relatively short half-life of 20 hours, but if your level is less than 10, it's consistent that that patient hasn't smoked generally within the last week or two. I put in vitamin D. It's got a lot of attention in the past year and a half with COVID as a potential beneficial treatment in helping with your immune system because we know it does play an important role in immune system modulation. The deficiency has been directly related to the development of periprosthetic joint infection, and well over half of our patients when tested are actually deficient in vitamin D, and it's easily and rapidly correctable. If they're less than 10, I usually send them to an endocrinologist. You can see the high doses that are needed to correct it. A lot of our patients fall within the 10 to 30 range, and they take 2,000 international units a day for 4 weeks leading up to surgery. MRSA and MSSA screening we touched on earlier in some of the other sessions. What we know is that a lot of the infecting strains that occur in a periprosthetic joint infection have similar DNA to what resides in your nasal cavity, your axilla, and other orifices. So our goal is to decrease this decolonization. There's 2 pathways, each have pros and cons. Universal screening, so test everybody, selectively decolonize those that are positive. The benefit of that is you identify who's positive and you can give them vancomycin. Logistically, it's easier just to universally decolonize everybody and just selectively give vancomycin plus Ancef to the high-risk patients. Perioperative antibiotics, Ancef remains the antibiotic of choice, cost-effective, rapid tissue bone penetration, gram-positive and gram-negative coverage. Keep in mind you have to have weight-based dosing. The routine use of vancomycin remains controversial, which you have to remember it has no gram-negative coverage, so in most situations you probably need to add something to give them gram-negative coverage. And the routine use, I think, again, is controversial and really should just be used for the true MRSA-positive patient or those with cephalosporin allergies. Penicillin allergic patient is rare, and I think it's important that you either screen for them with allergy testing, test dosing, or develop an algorithm, and we can touch bases on that. What are some things not to do? Routine urinalysis in patients. Preoperative iron and erythropoietin in the world of tranexamic acid, I think, has gone by the wayside. No Foley catheters, no aggressive anticoagulation. Avoid blood transfusions. Don't treat your operating room like a true theater and have 1 million people in there. And the routine use of vancomycin powder for all remains controversial. Thank you for your attention.
Thank you. That was excellent. Our next presentation is going to be a debate. It's going to be first Craig Delavalli talking about antimicrobial irrigation, dilute betadine, or something else. Always, what do you have to lose?
Thank you. I'm going to start my presentation by saying I have an important conflict of interest on this topic, as I did help develop the product Ccjr and do get royalties from that. So I think there are several methodologies employed to help reduce infection. Perioperative antibiotics, which Brian just talked about. Some have used topical antibiotics, special dressings, and many have employed some type of solution to irrigate the wound at the time of closure. I think the basic concept here is we all accept that there's some bacteria in the wound at the time of closure, but is there something we can do that's effective to reduce the number, to reduce the risk of clinical infection? My personal preference is the use of dilute betadine, and I'm going to share with you really 4 studies to support my position. This all really started for me way back, I think it was Journal Club 2005 or 2006. At Rush, we had a journal club, and we reviewed this article, and it was pretty compelling evidence, a randomized study, I believe it was in spinal surgery, showing what I think is a clinically relevant and statistically significant reduction in the risk of infection when using a dilute betadine lavage. So I started incorporating that in my practice, and then we decided to kind of retrospectively look back to see if it made a difference. And basically, we looked at 1,800 some odd cases before I used dilute betadine and almost 700 afterwards. We looked at the prevalence of acute periprosthetic joint infection within 90 days of surgery. And this is what we found. We found, again, what I think is a clinically important difference in the risk of infection, and then one that was statistically significant as well. So many of you who know me, then the next logical step with this seemed to be a randomized control study. We did this with our revision population because, as all of you know, when you do a power analysis of this, the more common a complication is, the more manageable the size of the numbers are that you're going to need for your study. So we published this a couple years ago back. Basically, what we did for our power analysis, it determined we needed about 300 cases in each limb of the study. As you can imagine, 600 patients, a randomized study. Even at a tertiary care center at Rush, where we do a lot of revisions, took a bit of time to get all these patients together. And basically, at our second interim analysis, we'd identified what we thought was, again, a clinically relevant and statistically significant reduction in infection, so we wound up actually stopping the study early. We had 234 patients that got the saline lavage, 223 that got the betadine lavage. And again, this is what we found. And at this point, again, this was a planned interim analysis. We had what I thought was a clinically relevant reduction as well as statistically significant, so we stopped the trial at this point. And then finally, there's a basic science study that really was Jay Parvizi did at his lab with some input from some other people. And basically, they looked at all these common solutions that people utilize. And some of the efficacy stuff is pretty interesting, particularly for what folks use in practice. Polymyxin, saline, and Castile soap were not effective at killing E. coli or Staph aureus. So I think that suggests to me that any of those preparations should not be used. And bacitracin solutions are actually still used relatively commonly. They can also cause allergy, and they're also quite expensive. So I would look at this paper if that's something that you utilize. Vancomycin worked against Staph aureus, but not E. coli. Gentamicin was effective against E. coli, but not Staph aureus. And povidone iodine, chlorhexidine, and sodium hypochlorite were effective against both. So the next step in this study was to look at safety, and they exposed all these different solutions to fibroblasts for 1 minute and for 3 minutes. And basically, povidone iodine showed the lowest cytotoxicity amongst the efficacious solutions, and chlorhexidine and Castile soap showed significant toxicity to the soft tissues. So I think in summary, it's my belief, and I think with these 4 papers, I've demonstrated that dilute betadine offers a simple, efficacious, and safe option for reducing the risk of periprosthetic joint infections. Irrigation solutions with antibiotics appear to have little efficacy, and other agents appear to be more toxic to the soft tissues. Thank you very much.
Thank you, Craig. Now we have Rafa Sierra, who's going to give the contrarian view, no value, waste of time and money.
Thank you very much. You can pull up the presentation. Thank you. These are my disclosures, non-pertinent to this talk. So as we heard, there are a number of irrigation solutions that are currently used for prevention of PJI. The goal of this debate is to actually, I thought it was very pertinent to debate the use of dilute povidone iodine solution. So we know that there are a number of PJI mitigation strategies. Some of them have more evidence than others to implement in your practice. If we look at the WHO guidelines for prevention of surgical site infection, these are the guidelines that you should absolutely have in your practice in order to prevent prosthetic joint infection. The WHO also has published a number of what they call, through those, conditional guideline recommendations, and many of these are conditional specifically because they have a low level of evidence. And among those is the use of povidone iodine irrigation, which in fact has very low evidence and has been introduced in addition with a number of mitigation strategies into practice. So the actual value of using this povidone iodine is actually questionable. So let's look specifically at this paper. This paper looked at the timeline of the initiation of different mitigation strategies into practice. You can see that in 2012, dilute betadine irrigation was used, and 9 months later, there's an institution of preoperative patient optimization. And we can see a steady decline in the number of infections that occurred over several years, but once povidone iodine was instituted in 2012, the total knee arthroplasty infection rate was actually the same as 2012, and the total hip arthroplasty infection rate was the same as 2011. So in this paper, actually it questions the value of adding povidone iodine to your mitigation strategies. We've actually published 2 papers, one in primary and one in revision arthroplasty, and our 1-year rate of prosthetic joint infection was less than 1% for primary joints and about 4 to 5% in revision arthroplasty. This is after 2 decades of implementing a multimodal infection prevention strategy, so our infection rate is quite low. The fact is, in these 2 studies, we were unable to detect a difference in infection rates with the use of povidone iodine versus not using povidone iodine. And it's likely the result of, again, 2 decades of using different mitigation strategies to prevent infection. This has been supported recently by a systematic review and meta-analysis of 6 retrospective reviews. Some of those papers that were discussed by Craig are in here, 1 randomized trial, and they found no difference at 3 or 12 months between groups that used povidone iodine lavage and those that did not, for either hip or knee replacement. So no difference in postoperative infection rates. So let's critically assess this paper that Craig just presented. I have the utmost respect for Craig and his team. They showed, again, a 3.4 to 0.4 difference in infection rates with a p-value of 0.038. The problem is that they kind of got screwed with their statistics, and there are 2 main reasons for this. Number 1, they did an a priori analysis, and they were supposed to collect 300 patients per group, but they actually randomized 478. They did an interim analysis at 300 and 450 patients. And the problem is that when you perform an interim analysis, you actually have a penalty to pay. And the overall type 1 error increases, and you have to actually use an alpha spending function. So with an interim analysis of 450 patients, their p-value should have been 0.016. That means that their p-value of 0.37 that they presented is actually not significant with the 450 patients that they've randomized to their study. In addition to that, there are some issues with toxicity. We know that it can cause systemic failure, kidney failure in some patients. And the first paper that actually looked at the use of povidone iodine saw that they actually had to dilute it to a 0.001% for it to avoid fibroblast toxicity at 24 hours. Subsequently, there are some practical issues with its use. It needs to be sterile, and not everybody has access to sterile povidone iodine. Again, the appropriate strength is unclear. According to a recent paper by Spangel, it needs to sit in the wound for 3 minutes and lavaged. I'm not sure about the 18 seconds that was shown in the video today, and it has to be cheap. So in conclusion, there are a number of mitigation strategies that actually have very strong evidence that should be implemented in your practice. There is very low evidence to demonstrate that the benefit of the use of povidone iodine lavage, and there are some ongoing randomized trials that hopefully will be able to answer some questions about this. So I'll leave you with this final quote. Almost 60 years later, we're back to the same thing. The overall history of skin antiseptics may be viewed as a repetitious story of antibacterial agents enthusiastically introduced, uncritically and widely adopted, subjected in time to more critical evaluation, and eventually discarded by a disillusioned or dissatisfied profusion. Thank you very much for your attention.
Great, thank you. That was excellent. All right. So, I listened to both of those presentations, and after Craig's, even though I normally use betadine only in people who are really high risk, I was ready to use it on everybody, and now I don't want to use it on anybody. So, so tell me what I need to do, Craig.
In terms of, well, I mean, again, I think the data suggests that I've looked at and that we've generated that it works. So I think it's a pretty simple, easy, and inexpensive way to reduce the risk of PJI. And again, I would submit there have been very few, if any, other studies that have actually shown that anything that we do reduces the risk of PJI. So,
Craig, we have a lot of questions from the online audience here about some of the specifics when you're using betadine. So can you tell us what the concentration is that you use, how long you leave it in the wound, and then do you need to wash it out when you're done?
all great questions. So what we were doing before is we made ourselves a betadine solution that was 0.3%. Now we use something that's commercially available. And actually the economics of that can be interesting because depending on how much your pulse lavage costs, at least for us at Rush, if we don't use the pulse lavage and we use the commercially available betadine solution again, and I get a royalty stream from that, we actually save quite a bit of money, at least with the pricing for the pulse lavage at Rush. In terms of how long to leave it in the room, I'm a posterior approach hip surgeon, so I put the betadine in the wound, and while I'm closing the posterior capsule, I let it sit in the wound. And then before closure, I do remove it. I mean, I would tell you, we've used this now for 15, 16 years, and I don't think I've ever seen a case of local or systemic toxicity associated with it. So, I mean, the recommendation is to remove it, but I don't know if there's a big downside if you didn't want to remove it for some reason.
And what about the issue of chondrotoxicity in your unis? Are you using it with unis?
No,
or
our
is it
uni
just for
infection
genitals?
rate is so low that we haven't. You know, the data on fibroblasts suggests that it's pretty safe to use. You probably could use it, but I don't know that for sure. We just don't have that experience to know for sure. And again, the infection rate in uni seems to be so low. I guess the more relevant thing would be if someone has an unresurfaced patella in a total knee, if that's a risk, and I just don't really know the answer to that. Jay Parvizi may want to opine because he's done a lot of the basic science work on it.
So just before Jay replies, if we could just please have Tom Faring and Tom Skolko also join us up here.
Yeah, so all antiseptic solutions have fibrotoxicity, toxicity against fibroblasts and chondrocytes, and the commercial product that's available is no exception. There is some degree of chondrotoxicity associated with all the antiseptics.
And Brian
The
Springer.
unis, you can, if it's a high risk, maybe its use is justified, but as part of the FDA process for approval, huge number of animal studies were done for both the toxicity against chondrocytes and fibroblasts.
Jay, question for you about the microbiome. It's certainly an intriguing idea. Should we be looking at doing microbiome assays on patients prior to their arthroplasty, both for a baseline and potentially perhaps to triage them? You know, should we be worried about the biome in some of these patients with arthritis?
Great question, JB. We just actually published that paper in Scientific Reports yesterday about the microbiome of knee and hip. Canadian group have published on the microbiome of shoulder. Very distinct group of organisms live in our joints. If you thought that your joints are sterile, that's not true. About 30 to 35% of our primary osteoarthritis patients undergoing surgery had a microbiome signal. Interestingly, it's much higher in the osteoarthritis than it's non-osteoarthritis, so we have some samples from patients undergoing ACL reconstruction or meniscus surgery is not the same. This question has an implication because there are now agents that you could administer, like forms of probiotics like Michael Otto from NIH showed, or prebiotics that will alter the microbiome profile and could potentially reduce the risk of infection.
So Jay, as far as looking at the next gen sequencing, how confident can we be that when things are being amplified DNA, that it's not dead DNA? And what is the threshold where we can be confident that this is truly viable organisms in a joint? And you already addressed the microbiome issues.
Yeah, that's a great question, Charles. So 3 things that need to happen when you're getting the results back from next-generation sequencing. One is the bioinformatics. And in the bioinformatics, they set the threshold. They also set the homology, the DNA homology with the organism. So the lower the homology, the higher the contamination rate, et cetera. The second is that we must realize that that's not false positive. It's not like culture growing something. The DNA signal is there, but it may not be true pathogen. To answer that question is we have done a parallel study with the RNA to see if the RNA and DNA of the same organism, and there was 98% concordance. So we're pretty confident that DNA signal is real.
Okay. So just a couple questions from everybody along the panel. Brian talked about the risk factors for infection, and obesity obviously is one of them. So how many people will restrict care, and how do you handle the obese patients? Do you have a BMI threshold, a cutoff? Do you recommend weight loss? And if they're successful, they get surgery. If they're not, they don't. How does everybody handle that starting down at the end?
Yeah, so, I used, just everything that Brian showed from an optimization standpoint. So the obese patient is the hardest one. We currently send patients to what we call the regenerative endocrinology clinic, where they work with their diabetes, obesity, try to get them down. And if they're able to get down to below 40, then they deserve an operation.
For patients with a BMI of 40, we mandate that they go to medical weight loss. And for BMI of over 50, we mandate that they get a surgical consult for weight loss. Understanding that this is part of managing their overall health, particularly for the surgical weight loss. I'm not 100% sure that that's going to decrease their perioperative risk, but I think it's good for their overall health. And I think it is a teaching moment where we as orthopedic surgeons can have an influence on someone's overall health. So I don't mandate that they get surgery, but I mandate they at least go get the consult to learn about it.
So I don't, I don't have a cutoff. We will schedule people 2 or 3 months from seeing them that have a high BMI over 40, but we will mandate that they see a nutritionist, they begin a program, they address all their modifiable risk factors, including smoking. We do the hemoglobin A1C, they see their internist, they check with their dentist, and do everything we can. And we schedule them 2 or 3 months, and it turns out that only about 55 or 60% of those patients that have a BMI over 40 actually fulfill. And then we'll give them a second chance, and then it's another 20%, and then that's it. But they have to really address these modifiable risk factors, and we'll do the surgery.
So does that mean they have to have lost weight, or does it just mean they have to have their sugar under control, their other modifiable health factors in good shape? So
they have to see a nutritionist. They have to be in a program. They typically will lose a few pounds, but they're not going to. We can't expect them in a few months to have lost the weight they need, or telling them to lose 30 or 40 pounds. That's not what we're going to do. We want them to at least be addressing their health if we're going to do their joint replacement. Or at least that's our philosophy.
I have one caveat, and Brian and I work in the same shop, and Brian's done a great job of all these modifiable risk factors that we take into account. But beware of the obese person with skinny legs. That we want to do a total knee on, we go, yeah, his BMI might be 44, but he's got skinny legs. I'll go ahead and do him. So we just published a paper comparing a group of patients with large girth versus the obese person with skinny legs. And it turns out the metabolic syndrome is much more important. Those patients who are big and have skinny legs are just as much risk as the overweight patient with thick legs. So be careful of that.
I think that's true, but again, if you're managing all the other modifiable risk factors, the diabetes and everything, then you're probably getting a lot of those metabolic syndrome people if you're getting all the other factors under control.
Charles, we had some questions online that I want to make sure we get to about diabetes. Specifically, are people checking A1C, fructosamine, both or neither? And I wonder if we could just go down the panel and just quickly let us know what you're using when it comes to your diabetic patients. Maybe, Rafa, if you'll start.
Hemoglobin A1C, I have not been using fructosamine.
Same here.
Fructosamine.
So A1C is the initial screening, and then the fructosamine, as I mentioned in the talk.
Yeah, the same 8 is our cutoff, our cutoff. But as was pointed out, if you get somebody who comes in with an extremely painful hip or collapsed femoral head, and their hemoglobin A1C is elevated, and you tell them it takes 2 or 3 months to get it down. So it can be a real problem for the patient. So we sometimes will bend on that.
I used hemoglobin A1C, fructosamine, as part of a research that's funded by American Association of Hip and Knee Surgeons. We're also exploring another agent called GA, or glycated albumin. It was described by Japanese, and it looks like GA may be even better than fructosamine in the long run.
So hemoglobin A1C, but if somebody has been making good progress, they're seeing a endocrinologist and they're on a new regimen, we may check a fructosamine to see if that's better.
Well, I had to operate on one of my senior partners who came in, and he had retired, and he came back, and he was obese now, and his A1C was 10. And I had to say, okay, well, I've got to stick to my guns here, and we got him down to 7.5, turned his life around. So I do what Brian does. 8's the screening test, fructosamine in a month to see what progress they're making. And if they can get their fructosamine down, then I'm going to do them.
I think that's all the time we have. Thanks for an excellent panel, and thanks for an excellent session.
Good job.